Let's move on now to our second presenter, and this is going to be by Dr. Robert McKenzie, who is going to talk about community access to naloxone, understanding the global opioid crisis in Milwaukee County, United States of America during COVID-19. Robert McKenzie is a graduate of our university in the School of Medicine, class of 2014. He's expected to graduate from the Master of Public Health program in 2021, so he's going to be one of our alumni. Robert completed his practicum experience as a remote research assistant on a COVID-19 knowledge, attitudes, and practice project in Grenada, learning the various roles of being a researcher. He currently resides in Milwaukee, Wisconsin, where he has used his capstone paper to address a pressing local public health issue, opioid overdose mortality. Robert plans to undertake his capstone research in his home county of Milwaukee following approval by the SGU Institutional Review Board. So Dr. McKenzie, we look forward to you now giving us some information on this other epidemic that is going on that may have gotten some shade because of COVID-19, but still is there, the opioid crisis. Dr. McKenzie.
Thank you very much for your kind introduction there. Hope you're seeing me okay. Am I getting through?
Yes, you are.
Okay. All right. Good morning. And thank you for the introduction. I'm in Milwaukee. And this is an opportunity, let me share my screen here, to continue research in a time when our access is to regular research methods may be curtailed, and COVID is detracting resources from other ongoing public health issues. So there's a tremendous problem here in Milwaukee, and overdose in the nation in general as part of the opioid crisis. So this is going to be a cross-sectional study it's going to be online using a SurveyMonkey to identify barriers, specific barriers to why people do not have naloxone, the rescue antidote for an opioid overdose at the time of an opioid overdose. We're going to be recruiting a target population from opioid users and their friends and associates, people that might be on hand to witness an opioid overdose. And it's a fairly straightforward situation. And because it's done remotely and with not a lot of resource inputs, it can be done relatively economically. So we're predicting a budget which is still coming together of about almost less than $2,000. So I first became interested in this problem last year. I was reading the news over the weekend, and every time you opened your computer and looked, there were another 3 opioid deaths, and it was like waiting for election results. It was concerning. And so by the end of the weekend, 14 people had died in Milwaukee, just the city. And I thought, well, this is probably a bad batch of opiates coming through, opioids. Fentanyl got mixed up in it, and people got blindsided by this. But as the stories came out, it was a mixture of etiologies. Somebody had overdosed on Suboxone. Another person, it was oxycodone pills that they were actually prescribed. And so I started focusing on the problem of, if you've got this terrible this wave of mortality, maybe you should just focus on an emergency measure, stop the bleeding, as we like to say. And then the problem hasn't gone away, because the same thing happened in May of this year, 14 people in one weekend. So yeah, the problem is dire in the United States. We're all familiar with the opioid epidemic. It's 1/3 as bad again in Milwaukee County, probably because it's an urban area. And opioid mortality surpasses homicides, suicides, and gun violence combined. And that's a general trend. So the projection, All right. COVID did not make things better. So in addition to the stresses that this opioid using community already experiences, it's a vulnerable community, and when an additional stressor is placed on it, it affects them disproportionately. So there's less resources, of course, for substance abuse disorder treatment. And, but also people are, the traditional things that can ameliorate the situation of somebody with substance use disorder, group counseling, peer counseling, it's no longer available to them. So you add in the isolation, the quarantine, the stressors, people are using more drugs, and they're being affected by them disproportionately. So another thing and people with substance use disorder are 8 times more likely to get COVID-19. And when they do get it, it hurts them more because they've got cardiovascular vulnerabilities, they've got respiratory pre-existing conditions. So just to give you an idea of the scale of the problem, we went from about annually 300 overdoses a year to now they're projecting somewhere between 515 to 640 overdose deaths. And that's in addition to projected 200 homicides, 100 vehicle fatalities, and about 400 COVID deaths. So opioid overdose is projected to take more lives in my county this year than the COVID crisis. So, and this is another interesting thing. This is affecting everybody, all demographics more or less equally across age, ethnicity, socioeconomic status, and geography. This is a map, an overdose map of the county. And, even though there's urban centers, this is it's really suggestive that there's something mechanistic occurring. It's, it's not specific to any group. This is something very general to the process of using opioids, and it's not demographic. So it suggests that there would be a general solution. And so Narcan is what I'm focusing on here. We've been using it for years. I'm sure we're mostly all familiar with it. It reverses the effects of opioid overdose immediately. It's got no side effects, and it can induce opioid withdrawal in some individuals. And it's got no potential for abuse, which kind of sets it apart as some of the medications used to treat substance use disorder. So, and it works, and people are using it a lot in this county and nationally. For every opioid overdose, there are 5 people that are resuscitated with naloxone. And this is the data from 2018. And I found other data from 2016. Of the 300 people that died that year from opioid overdose, only about 40 of them received naloxone as a rescue intervention. And only 7 of those people were not first responders. So it suggests a possibility that if you can get naloxone into the hands of people in the community and into opioid users' hands themselves, then it will be in position, and if they know how to use it, you can start saving some lives. And the purpose of this study is, why don't people have naloxone? So here's just a bit of history. There's been a tremendous effort at the federal, state, and local level to increase community access for naloxone. It was formulated as a nasal spray, authorized as a generic. And then in Wisconsin, the state of Wisconsin, there's a standing order as a state law that you don't need a prescription for naloxone. You can walk into any pharmacy, and if you can afford it, you can get it in your hands. So the question remains, why didn't 300 people last year, and more this year, why is this not happening? All right, so in addition to that, if you can't afford it, there are 70 organizations within the state of Wisconsin, community organizations, that are funded to distribute naloxone and train people in its correct use. And 12 of these are in Milwaukee County. So let me advance this. Right, so the study is going to be an online survey through SurveyMonkey. I've already reached out to 2 of these community organizations, and I have they've verbally committed to helping me to distribute the survey to these vulnerable populations, the opioid user population, and their friends and their associates that might be on hand to witness an overdose event. So Right now, the idea is to make a QR code to the link, distribute that to electronically, have these organizations, they can print it out and people can scan them. Not everybody in the opioid using community has a cell phone, but it's a general enough modality that in the time of COVID, I think it represents a plausible strategy. So these are the research questions that we're looking into. And the idea, the specific goal of the study is to find out why people do not have naloxone in their possession. Do they not know where to get it? Is the word not getting out about these community organizations? Do they know how to use naloxone? Are they familiar with the different forms of routes of administration? Can people identify an overdose? You know, the respiratory depression of an opioid dose. Do they think it's illegal? Do they not know that they don't need a prescription anymore in Wisconsin? Personal beliefs. It's becoming apparent that some people, some opioid users, have a Superman complex. They just think it's only going to happen to the next guy. They're too smart to fall into that trap themselves. And also, are people concerned about exposing themselves to the to legal harm? If you're in this country as an undocumented person, concern about deportation and ICE is a very real fear, especially in some of the communities in Milwaukee. And also, the price of naloxone. The price of naloxone has gone up tremendously. It's jumped 120% between 2012 and 2015. There's an auto injector reform that went up 500% in 2 years. So the monetization of the healthcare system is, you know, it's costing lives here and on the ground. So that's something to take a look at too. So it's a modest study. The sample size is 400. We of course are going through IRB approval at St. George's University. We'll do a pilot study, fix the bugs, and then roll it out. And hopefully we can disseminate these findings to publish them. And also, it seems that Milwaukee County is a sort of a modality, a set of circumstances that can be readily applied to other urban situations too. So, and even if what we find out is people didn't have access to naloxone, or that they did have it, but they overdosed anyway because they couldn't self-administer, then that would indicate some other strategies that might reduce mortality, such as safe spaces where people can inject opioids and be monitored, are also the encouraging of practices, such as using drugs together or injecting opioids together so that there's somebody else in the room, that if somebody goes into respiratory distress, the person will presumably have naloxone, be able to administer them and save their lives. So I think it's a useful, relevant study, and it's modest, but it's practical, and I think it's could make a contribution to public health in my community where you can actually see something happen. So yeah, thank you for your time.
Thank you so much, Dr. McKenzie. Very relevant question. We have two questions that have popped up in the chat. One question is, are police in the Milwaukee trained on how to use naloxone if they find someone who has overdosed?
Oh yes, that's first responders. It's just a matter of course now, especially police, firefighters, and medical personnel. They carry it with them, and so that's one of the reasons why in our target population we've got inclusion and exclusion criteria. First responders are not going to be asked to participate in the survey because it is assumed that they already have naloxone with them.
Okay, thank you. And the second question is that some have heard that it can be illegal to be in the same room as someone who overdosing on a substance, which obviously reduces the risk to call someone from the emergency responder. So what do the laws say in Milwaukee You get in trouble if you call because you observe someone taking an opioid and overdosing?
No, I think that at this point in Milwaukee, there's no stigma attached. There's no legal stigma. There's an implied amnesty at this point. We're not to the point where Portland is. They've just passed a law where having small amounts of opioids in your possession has been decriminalized. So there's still a legal concern about being in possession of drugs, but just being in the same room with somebody, there's I wouldn't anticipate that would be a problem, but it's definitely something to see what people are thinking about and see what the current level of awareness is in the community.
Okay, and questions are coming in fast and furious. That's
Great.
good. Another question for you, Dr. McKenzie. Can you clarify why the overdoses in big, why this epidemic? Is it the prescription, people taking and abusing prescription drugs, or is this people illegally supplementing their drug habits now with opioids instead of the other usual suspects? What is driving this these overdoses?
Well, I don't have a specific bit of evidence from you from a research paper at my fingertips, but the common way of looking at this, the prevailing zeitgeist, I guess, is people start on, it's the same thing that's driving the opioid epidemic nationally. People get started on pills, they go to heroin on the street. It's far less expensive, it's more readily available, and then they go downhill from there. Interestingly enough, the opioid overdoses are a significant part of overdose mortality in Milwaukee, but people are also dying of cocaine and methamphetamine. And of course, fentanyl. It's combinations of these things. People are abusing Suboxone. Gabapentin has become a drug of abuse lately. So people are taking these cocktails of drugs. I have to admit, I don't understand it, but it's what we're seeing. And the opioids are a primary driver of mortality. So that's what I'm focusing on at this time. And again, it's something you can do something about. There's an antidote for it.
Yes, in fact, I really appreciate this presentation and you giving it to us. While COVID-19 has understandably taken the lion's share of public health professionals' focus, other epidemics like the opioid epidemic within the United States have not gone away. And as you have indicated, tragically will even take more lives than the COVID-19 pandemic in your neck of the woods. So it's something we need to focus on. I just had one question I'd like to ask you. I've been to a presentation where when the opioid crisis was raging, and as you have indicated, it still rages, where some were saying that they face a challenge among people within their own communities, professionals, who argue that if you make naloxone readily available to someone who is ODing or can OD or is using opioids, you actually encourage them. That was the argument that was given, that if you give them the opportunity to rectify an overdose, then you're not encouraging them to quit. And so there was pushback from several segments of the community from making naloxone readily available. They actually argue make it difficult. Is that you have that situation in Milwaukee, your county, where people are actually advocating to not make naloxone readily available because the fear is that if you do that, you then encourage people to continue their habit. Is that a potential barrier?
Well, that's interesting. You can appreciate the concern standing back and looking at it from a distance, that if you so to speak, normalize injection drug use or normalize the use of opioids, then you are encouraging it. But to be honest, I haven't seen that. I haven't registered as a concern. When you're confronted with a public health crisis of this magnitude and this just the rhythm, the stunning regularity of it, I think people are sort of moving beyond that. Having rescue naloxone on your person is essentially responsible. If you're going to be treading in these waters, so to speak. But what's also recommended to have on your person is fentanyl test strips. Now, I don't know a lot about this, but apparently you can, it's a test that you can conduct in the field, results in moments. People can do it themselves and find out if their heroin or their opioids has fentanyl in it, which I think we all recognize as a clear and present hazard. It's unpredictable and it drives a lot of mortality. So, and the same argument could be made about having safe spaces for injection drug use. You'd save lives, but I think that you will see some resistance in the community to this because people don't want to, they don't want to see that. But I think it will save lives, and so in the long run, we will see these strategies be employed on a community level.